Okay, great. Well, thank you, and I appreciate the introduction and the opportunity to talk again at this class. So I know you've been hearing from a bunch of different people, different perspectives, and I think it's great. If you got all the people who've been speaking to you into a room, it would be like a great cocktail party, because we all come at this epidemic from sort of different vantage points, and mine is a specific vantage point as well, and what I think each of us have to do is try to compel you to think ours is the most important thing. So if someone comes and talks to you about mother-to-child transmission or poverty or people living with HIV in Africa or Asia, each one of them should make a really cogent argument that all the funding should go to them. And so I'm going to try to do the same sort of thing, but talking about people who are locked up. And as I'll try to do over the next 30 minutes or so is lay out sort of a thesis that people who are locked up, people who are behind bars in our country and probably in most countries represent a very important component of the HIV epidemic, and that incarcerating people actually plays into the epidemic in all sorts of ways. So I'll get things rolling, and I use the slides not so much for telling you, the information. It just reminds me of things to say and can be a starting point, and it's not supposed to be the definitive beginning and end of what we can talk about with this. So hopefully you can read this. So this is a real-life billboard, and it's also true. So we incarcerate about 25% of the world's prisoners, even though we're only 5% of the world's population. So currently in the United States, 1 out of every 99 adults is behind bars. So 1 out of 99. I think if we had passed out a survey and said, guess at what proportion of people in this country are HIV positive, I think probably the minority would guess as high a number as 1% or so. So it's really incredible. And we, even when you look at it per capita and look at people who are incarcerated in other countries, like Russia and China, we still per capita incarcerate more people than other countries do. So by absolute numbers and by percentages, it's really astounding. And the number of dollars that are spent, the number of lives that are impacted by this is really hard to get a sense of just with a number. So it's just an astounding part of our society, but one that conveniently is absent from most of our daily lives. We may drive by a prison facility with the brown sign and the barbed wire, and we don't give it a second thought. It's almost like we don't even want to think about it. And these are often tucked away. They're on the sides. They're not in the front and center view. And I think one of the most amazing things that I've appreciated having a career in medicine is it allows me access to places that we don't normally go, both physically, and also, I think, virtually, through people's lives, through their stories. You learn a lot when you talk to people who are coming to you for medical help. And my work, I think, has expanded to allow me to do that and allow me to probe for more of that. So I think it's a privilege for me to actually be in a prison. It's amazing. Most of us don't end up going to prisons, especially voluntarily. And to get access to that and see what people are like and what lives are like and what's reality and not just fiction from TV or movies, I think has really been just a real plus. And same thing in other aspects of medicine, and I'm sure there are people in this room who are thinking about medicine, whether it's seeing a baby being born or doing or seeing an operation and a surgery. There are just these privileges, and this is one of them for me. So it's just amazing to me that there's this whole world, this whole culture, this whole aspect of our society that is huge, but which we keep somewhat behind closed doors, closed fences, barbed wire, and we don't think a lot about unless it affects us or people we know. So we incarcerate a lot of people. So there's several things that I think I want to make clear for you when we talk about criminal justice, CJ, and HIV. And I'll lay it out to you almost as I did for a group of researchers looking at this issue in the same presentation. It's going by what we know, what we don't know, and what we should do. What's the next steps? And so I do a lot of work in incarcerated settings looking at HIV and trying to understand why people have HIV in prison. I'll get to that in a second. How to get people who have HIV in prison and in jails to some extent into care when they get out. trying to understand why some people who have high risk and are incarcerated don't have HIV when they really should based upon their risk factors. So there's a lot of things that I think are interesting to think about, as well as how do we provide better care for people. And I go to the prison and I provide HIV care for those who are incarcerated. So what do we know? We know that many people who are HIV positive are incarcerated. So I told you that 1 out of 99 adults in our country are incarcerated, and I really mean behind bars. I'm not talking about probation or parole or community supervision. I'm talking about they're really behind some sort of, closed, locked cell or wall. So, but of the people who are HIV positive in our country, almost a quarter of them pass through a jail or prison every year. So this is the flip side. If you look at everyone in the country, but then you can look at people who are HIV positive, a lot of people with HIV end up getting locked up. And there's a history of that, right? We know why that is, because HIV, the epidemic of HIV, and the epidemic of incarceration are now overlapping and targeting the same populations. So communities of color, people living in poverty, people who use substances, people who do things so they can get money to buy substances like crack cocaine. These are things that we see. So there's criminalization of drugs. People who do drugs are at higher risk sometimes of having HIV. Ergo, we lock up people who do drugs, so we're locking up people who have a lot of HIV and hepatitis C, things like that. So we know we lock up a lot of people. We lock up a lot of people who are at risk for HIV. And if you've got that big net out there and you're pulling in the fish, you're going to pull in a lot of people with HIV. Many people who are incarcerated are HIV positive, and the HIV positive incarcerated have a higher prevalence of the things we're talking about: mental health disorders and substance abuse disorders. Disproportionately, my screen did something funny, so I'm just going to try to see. Disproportionately, what we see is that the epidemic has shifted, and I'm sure others have talked to you about the epidemiology of HIV over the last 20 years, and clearly the epidemic has moved and shifted into a totally different, it's okay, I just touched it like that, into different populations. So I'm writing a little piece for a magazine and trying to explain why HIV moves to different places. Why does HIV find niches? And it's not that HIV has neurons and has a brain, right? It takes no more thought for HIV to jump from gay white men in San Francisco to inner city, center city Philadelphia than it does raindrops to collect and form a stream and then go out to the ocean. This is just natural. This is just nature. This is just evolution. And it's a natural phenomenon. So the virus just wants to replicate. It just wants to make babies, right? So it just wants to find a good host to do that. And if it can't find a host in one group of people where it was doing well before, it will find another. Just like there's gravity and just like there's, natural selection. So that's what we see, is that it finds a niche, and as long as the behaviors allow the virus to propel itself, it finds a foothold that then becomes a safe sanctuary. So right now in this country, HIV is pretty well embedded in many, many communities that it found a niche in. And they're not the communities that were blighted, 20 years ago, because things have changed. So we see it in places where there's poverty. We see it in places where there's not been as much health access or utilization. So HIV follows trends. And someone can certainly come up here and talk to you about conflict and war and the HIV epidemic and displacement of people and what that does to behaviors that leads to transmission of HIV. Someone can come up here and talk to you about the situation in China, where there's an excess of men to women and how that propagates the epidemic in all sorts of ways. So these socially disruptive forces act in many ways on infectious diseases, whether we're talking about Lyme disease or we're talking about syphilis or we're talking about HIV. And that's what's happened here. When you take a large group of people and you incarcerate them for X amount of time and then bring them back to the community, that's disruptive. So it disrupts the relationship that may have existed prior to incarceration, okay, which then may break apart, and then the community partner, the partner who's left behind, hooks up with someone else, and if that community has a lot more HIV than it should, she now is exposed to HIV where before she wouldn't have been if that partnership may have been stable. Or maybe she isn't. Maybe the disruption of that partnership was the best thing that ever happened to her because he was fooling around with lots of different people and he could have brought HIV home to her. So there's lots of disruption that goes on, and we have to understand more about that. That's why I think this is fascinating. True, most people in prisons and to some extent jails, but certainly prisons, and I'll explain the difference in a second, get good care. So it's not like you get locked up and it's a dungeon and no one's going to care for you. People do relatively very, very well, and I'd argue even probably better, there's some data to support this, better than they do in the community once they get locked up. And it kind of is intuitive, right? You get locked up, you have limited access to crack cocaine or alcohol, you can get 3 square meals a day, you may exercise more than usual. So it's kind of cleaner living, and you get medicines for free, and there's doctors to see, and they monitor you. So people actually, I think, do better when they're incarcerated than when they're not, and they don't have those things, those structural sort of factors that help support them. So in my community clinic here at UNC, I'm dealing with all sorts of stuff. My double wide burned down, and my medicines were there with it, or my boyfriend beat me up, so I wasn't able to get my medicines, and can you find me a place to live? I don't have to find a place to live for people who are incarcerated. Okay. Other thing is that most people who are incarcerated get out. So here's the distinction between jails and prisons. So jail, for those of you who don't know, we use these interchangeably, and it kind of irks me, it's just because of pet peeve, like on NPR or something when someone uses jail and prison interchangeably. They are different. So jail is where you go generally when you're getting arrested for a crime, or a suspected crime, alleged crime. So they put you in jail until eventually you either post bail or they let you go until you come back. And then you go to court and you're found guilty, and if you're sentenced to time, you then go to prison to do your time. So jail is usually people who have not been convicted of a crime yet, or they're convicted for a crime that has a short sentence, so you just might do it in jail. But prison's for people who've been convicted in general. So there's differences, and they're run differently. Prisons are run by states, or by the federal government, or by the military. The jail is run by the local guy with keys, the sheriff, or the mayor. So municipalities, counties can run a jail. Okay. Problem is that when people are incarcerated, they do well, but when they get out, they don't do so well. So they don't do well at all, most people. They get out and they stop taking their meds. They get back with their homies. They're into some other stuff. They're not going to be, the priority is not, I need to take my pill this morning. The priority is, how do I integrate back into my community after I've been out for the last 8 months or the last 2 years? So again, bottom line that I want you to take home is that incarceration is disruptive socially, and it damages people's lives, both the people who are incarcerated, and has effects on the people who are in those communities where there is a lot of incarceration. Okay. So again, I think that this is saying a little bit what I said before. There's this sort of 4 horsemen of modern day domestic HIV. I would say mental health and substance abuse is key. And the people who are getting infected now, especially people who got infected over the last few years, oftentimes have something going on. There's some reason in this day and age. It's not that I was at the wrong bathhouse, in San Francisco, and I happened to meet the wrong guy and I got infected. That's not what we're seeing now. We're seeing that generally there's something else, that there's risk behaviors going on that are pathological. Okay, the internet. I think the internet is another factor in the spread of HIV. And this is another incredibly fascinating aspect of the modern day epidemic of HIV that some of my colleagues are studying. And people are using the internet, as you know, to hook up in ways that are really, really, really bad if you want to stop the spread of HIV. Poverty, I think, is obvious, and then incarceration. So these are numbers just about prisons. This is federal and state prison, and we have a lot of data from prisons. It's very hard to get data from jails. There's lots and lots, thousands of jails. Whereas there's only a few, there's 50 states that have prisons and then the federal system. So it's much better to get data from the prisons and easier than it is from jails. And so you can see, just looking from 2006 to 2008, which are the data we have, about 1.5% of the custody population is HIV infected. 1.5%. So that may not sound like too much, 1.5%. So it's like 1.5 out of 100 for the whole prison system. That includes Montana all the way to New York, down to Florida. But in the general population, what is it? It's like 1 out of 300 people. So this is many-fold higher than what we see in the general population, and it's probably an underestimate. We do not test everyone who comes into prison for HIV. It's not mandatorily done in most states. Some states it is. So about 19, 20 states test everyone who comes in, whether they want it or not. But most other states offer it in a voluntary way. So we really don't have good hard and fast numbers. It's probably maybe a little bit higher. so maybe around 2%. Still, it's pretty big. That's a few, tens of thousands of people. Okay. Here's the incarceration of the adult population. You can see it's really gone up, and it started in the 1980s. And I show this because the reason people are getting, the reason that we're catching so many people with HIV is this whole incarceration kick. We're addicted to incarcerating people, as I mentioned before, and a lot of it has to do with drugs. So the war on drugs, which was started in the 1970s, has really propelled this incarceration rate that's just incredible when you look at it. So there's about 7 million people who are incarcerated or under supervision at any one time. About 2.5 million, I think it's right here. Yeah, so about 1.5 million are in prison, add about another 700,000 in jail. So you're talking about, about 2.5 million people who are actually behind bars. And then the rest of that 7 million are under some community supervision. So there are people who live around us who are in the criminal justice system, but in a very different way. So it's really incredible just how many people we're talking about. Okay. Here's the data that I mentioned before, where you look at the proportion of people who are HIV infected who pass through a prison or jail. It's about 15 to 20%. But when you start looking at subgroups like this, if you look at all the African American men who are HIV positive, about a quarter of them pass through a prison or jail. This is important because what it means is that there are opportunities, perhaps, to diagnose HIV when people pass through prisons and jails, and that we miss this opportunity when we don't screen people. And we can talk maybe during the question and answer discussion period about whether or not we should be forcing people to get HIV tested or not. But this is what people point to, is that there's a lot of people who come through who are HIV positive, some of whom know it and some of whom don't know it. But clearly, I said the other day to someone, if you're looking for people who are HIV positive, you don't go to the airport. You don't go to the airport and start screening people for HIV. But it totally makes sense to go to prisons and jails to do it. Good news is that people do well in prison. If you look at their viral load, which you guys know all about, I'm sure by now, the amount of virus in someone's blood, the majority of people get their viral load undetectable. Here in North Carolina, about 75% of people who get released from prison have an undetectable viral load. So we know that's good, right? Because that's good for their health. If you have an undetectable viral load, your immune system starts to kick in again. You stay healthier. But it also means you're less infectious. So we like that. We like less infectious patients because that helps us not get more patients. So people do well in prison. The problem is when they get out, we notice their viral loads start to shoot up. And if the viral load starts to shoot up at the same time they're re-engaging in risk behaviors, that's a perfect storm for badness, right? Okay, so that's what we're worried about. I'm going to skip that. I'm going to skip that too. We know that people, when they get out, don't do what they need to do. And here are data from Texas, from our colleagues in Texas, that looked at people getting out of prison who are on HIV medicines and looking to see when they filled their prescription for HIV medicines when they got out. And they give them a 10-day supply in Texas. They say, here's your bus money, here's 10 days worth of medicines, goodbye and hope never see you again, right? And they put them on a bus and they go. And they say, okay, but you got to fill your prescription at the local pharmacy within 10 days, because after 10 days you're going to be out of your HIV medicine, your viral load's going to shoot up, you're going to be dripping with virus, you're going to be able to infect other people, and it's going to be bad for you. Well, at 10 days, they found that only 5% of people had filled the prescription. This is out of 2,000 people. By 30 days, it was almost 20%, and by 60 days, it was only 30%. Long after their medicines had worn off, after their viral loads had shot up. So we know people aren't re-engaging. We're doing, the worry is, well, are you going to take care of people in prisons and jails the way you should? We do. The problem is not that. The problem is the free world. People aren't doing well in the free world, and that's what we have to improve. Okay. We also know that when you get out, in general, it's a bad time for you. You would think that people just can't wait to get out. And it's true. If you ask people in prison, you want to get out? Of course they're going to say yes. But if you ask, are you worried about what happens when you get out? They're going to say yes as well. We've done a lot of interviews and focus groups with people, and this is a very anxious time. It's fraught with a lot of concerns. And one thing we noticed, and these are data from Washington State, but there's other data that we have from North Carolina and recently from New York that show in that 2-week period after people get out of prison or jail, the rate of mortality goes up substantially. So people often die right after they leave prison or jail, especially if they've been in for a while. Some of that is, you get out and someone remembers that you snitched on them and they kill you, or you get out and you thought, well, I could handle the same amount of, heroin that I handled before I got in when I built up all that tolerance and I overdosed. There's some of that, but there's also suicide and there's other comorbidities that occur. So it's fraught with a lot of difficulty for a lot of people, and it's a fairly dangerous period of time. Okay. So what I just went through is basically what we know. What I feel I can show you, there is data, what we feel confident about telling you. Here's what we don't know. I don't understand much yet about how the epidemic that's shifting in the free world is affecting incarceration. The kind of people we're seeing now getting newly infected in North Carolina are young gay men. Young gay men that I don't necessarily see in prison. Somewhat, but not nearly as much as I saw the kind of people that were getting infected before. 30, 40-year-old heterosexual men, or men who sometimes had sex with men, but usually had sex with women, or injection drug users. We're seeing it really shift into a different group of people who don't have as much going on as far as substance abuse or mental health disorders, some, but not as much, and who are really hooking up with other gay men, again, through the internet or other types of ways. And these are very, very young men. So I'm not sure yet how this is going to shift the HIV epidemic that we're seeing in corrections, and this is an open area. Also, to what extent is HIV transmitted in prisons and jails? Because that's what's at the forefront. When you heard there's going to be HIV in prisons and jails here, it's like, oh, this is all about how people get incarcerated, they get raped, they get HIV, and then they bring it home to their communities. And believe it or not, we really don't have a great sense of that, and the data we have to date shows that that may happen, probably does happen, and is probably fairly rare. And if it does happen, it's certainly not the leading edge of the epidemic. The majority of HIV we see in these correctional facilities came in. We test people when they come in, and we see 2% of people infected. You don't have to make up that they're getting infected in prison to understand how come there's so much HIV. Okay? I'm not saying it doesn't happen. I'm saying we don't understand how much, but sense is it's not going to be the lion's share of the HIV burden we see in these places. We don't completely understand what happens when people get out. That whole perfect storm I just described, with people getting out and their viral loads go up and they engage in risk behavior, we don't know what contribution people with HIV who get released from prison make to the overall epidemic. It's not been studied well. And we don't know how best to intervene to support inmates when they're out, so they're no longer having to deal with, working through a very complex healthcare system. So this gets to the first point, and this is the whole idea of, well, where is the epidemic headed and how's that changing things as far as what I do? So I think you've seen something like this before, if not this exact same slide, and it shows that, men who have sex with men makes up about, 57% of new infections estimated every year, if you include people who are men who have sex with men and also inject drugs. Heterosexual contact is like 31%, drug use 12%. So a lot of this has changed. This is not the way it was 10 years ago, and it's changed in many other ways too, in that this is a younger group of men. So we see that a majority of these young men are African American, disproportionately. We do still see African American women getting infected, and that's again another fascinating topic that could take an hour to discuss how that's happening and who's infecting them. But I'm not sure how these men figure into this incarceration epidemic. One way, and I asked a lot of colleagues about this, and you can't read this intentionally, I'm going to highlight what's important here. I asked people to tell me what proportion of people coming into prisons and jails nowadays are men who have sex with men. If you look in North Carolina, less than 1% of male inmates coming in say that they've ever had sex with a man, which is obviously just way too low a number. And why is that? It's because who administers that survey? It's somebody from the prison. And it may be an earshot of other prisoners. It's not very private information. So why in the world would you come in and tell someone that you're gay or you have sex with men when it can only lead to bad things happening to you because of the stigma that can exist and the discrimination? So I found this one study that one of my colleagues did, and this is a jail study, and it showed that it didn't look at how many people said that they were gay, it said how many people said that they were straight, and everyone else said other, or I'm not straight. And almost 80%, 75, 80% said that they were heterosexual. That meant, maybe about 20% were not heterosexual. So I think that we are seeing people who are in the target populations that are getting infected now in prisons and jails It's just maybe for a little bit different than what we saw before. And it may be more jails, more petty crime than what we saw before. We do know that there is some transmission within prisons, as I mentioned before. This was one study that was done in Georgia that looked at people who were tested on admission to the prison system, and they have mandatory testing in Georgia, and then were tested during their incarceration and found to be positive. So there was something like 38 of these guys who were found positive, and so we know it occurs. We just don't know what the denominator is, because this was over a many-year period of time. So I believe it occurs. I just don't, I think, and this is really important, but again, this is not the operative mode of HIV acquisition among people who've been incarcerated. This is a new concept, the cascade, that I think people are trying to get a better handle on and a good way to think about things, but I also think is helpful for us thinking about this question. So we know that for every 100 people infected with HIV in our country, 80 are aware of their infection, 62 are linked to care, 41% actually stay in care, 36% of this 100 gets HIV therapy, and 28% have an undetectable viral load. So this is an important concept. This is something we're really focusing on. These are very recent data that came out of the CDC. And again, this may be an opportunity that if some of these people up here in this part of the spectrum are getting incarcerated, maybe we could find them, get them into care, link them to care when they get out, and hopefully have a happy viral load. I'm going to skip that. So we did a study in North Carolina, and I just want to end with this so that there's enough time to talk, where we looked at people coming into prison over this time period, from June 2008 to April of 2009. And a couple of things happened during the course of this study. We took blood that was left over from other testing that was being done on every inmate and used it to test for HIV anonymously. So we looked for HIV in blood samples of people coming into prison. So there's 20-something thousand people coming in during this time period. Under the first half, this was under opt-in testing. This is when you say to someone, do you want an HIV test? And the person says, okay, I'll take the HIV test. Okay, you have to sign this paper that says you want the HIV test, and then I'll do the test and I'll tell you the results later on. That's under opt-in. Opt-out is a different type of testing. Opt-out is what we do normally in a lot of medicine, which is I order tests all the time on my patients. They don't know the exact tests I'm ordering. I don't say I'm ordering a potassium and a chloride and a bicarbonate on you. I say I'm going to order some tests, some chemistries, look at some different things. Is that okay? And someone says, yeah, I'm going to go to the lab and I'm going to let them take my blood. Under opt-out testing for HIV, you can say, we're testing for a whole bunch of things, including HIV. Any problem with that? No? That's it. No signed informed consent, nothing. The CDC recommends that we move to opt-out testing in all healthcare settings, including prisons, jails, emergency rooms, primary care settings. So we did that. So we shifted from opt-in to opt-out. Here's the proportion of inmates coming in getting tested. It went from around 60% to over 90%. So we've got a lot of people now getting tested who weren't getting tested before to try to see if we can get in that front part of the cascade and identify people who are HIV infected. You can't really see all of this, but what it shows us is that when we did this, we found more people got tested, including more people who had HIV. There were 360 people with HIV during this time period, and 160 conveniently under opt-in, 160 under opt-out. But of the people we identified with HIV through the screening test, through the study test, the majority of them had previously been tested outside of prison because we looked at state records and we were able to link them before we de-identified the specimen. So again, there's a lot of work we have to do. It's fascinating that we think that if we go to the prisons instead of airports, test people for HIV, we're going to detect people who don't know that they're HIV infected, help them out so much by getting them on therapy and counseling them. But what we found in North Carolina is pretty limited. Maybe 5 people for testing 23,000 you would find who are in that category. So we have a lot to learn, and there's assumptions. We're learning all the time not to have assumptions, that we have to understand more about it. This was a surprising result for us, that most people who'd come in had already been diagnosed on the outside. Okay. There are efforts to successfully link people to care after they get out. I'm not going to go into it. We found that it's very hard to do. How about data describing risk behaviors of HIV-positive releasees? You can ask me and say, well, what about people who get out of prison? What's their risk behavior like? What do they really do? We always joke that there's 2 things you want when you get out of prison, and one of them is a Big Mac, right? Where's the data? Well, here's the data. We don't have good data. I searched, high and low, emailed colleagues. I don't have anything to show you. We don't have good information about what's the risk behavior of HIV-positive people coming out from an incarcerated setting. Most of the data we've collected here in North Carolina show that the minority of people actually re-engage in sex within the first month, less than 20%. But it takes a while to build back your relationships and your connections. So this whole concept of people getting out and they're dripping with virus and then they're re-engaging in risk behaviors because they've been deprived of sex, it's a nice story, but we're not really seeing it pan out in most of the work we're doing, at least here. It may be different in other places. Okay. So here's this whole continuum, and this is how I'll leave it. I think that there is an opportunity during incarceration to do as best as we can to find people with HIV, because it's still a good idea, treat them effectively, which I think we're doing, and then link them to services both within the prison for mental health, substance abuse disorders, what they need, and then link them to care when they get out, and maintain the benefits that are achieved in prison, which isn't happening right now. And this is really just a big, I mean, it's an irritant and it can make you angry. I mean, we're spending tons of money on people in prison to get their viral load down, to counsel them, to do what we need. And then they get out, and we're not spending hardly anything at all, and all that investment gets washed away by the wayside. So I think that this is really a cause for concern and agitation and advocacy. And then what about this reincarceration? Because there's a cycle. You know, maybe 40% of people get reincarcerated within 2 to 3 years. And then this whole thing happens all over again. So I think that there's lots of opportunities, lots of research opportunities, lots of community action opportunities here that are not being taken advantage of. And for me, I think that this propels the spread of HIV in a number of different ways that I've already kind of overtly or maybe more covertly hinted at, which is certainly there's things that happen to people. Eventually they get out, eventually they stop taking their medicines, and eventually they do re-engage in risk behavior. I just think it's not the same way we think about it, but it does occur over time. So there could be an infection that does occur from people who are released. It makes sense. And then we know that there's downstream effects. Again, like I said, what happens to communities where there's too few men? When 12 or 13 or 15% of the men in a community are locked up, what happens to gender relations? What happens to gender power? And that's something that I think we've already witnessed, that there's a reason why there may be more women getting infected in some of the same communities where there's a lot of incarceration. So what should we do? I think first is recognize that there are toxic effects of massive incarceration. There's no other way to describe it. It is massive incarceration in this country. It just doesn't tend to affect the people who are like us. It sometimes affects people who are not like, at least me. Take advantage of the opportunity presented by incarceration. Okay, it's there. Let's maybe leverage that to apply, a paradigm of let's find people, let's counsel them, let's get them into care, and let's render them less infectious and help their well-being. I think we have to advocate for implementation of evidence-based interventions. There are things we know that we can do. They're just like substitution therapy for people who are addicted to opiates. So try to find methadone inside of a prison. Try to find condoms inside of a prison or bleach. You're not going to find those things, even though there are evidence-based interventions to reduce transmission. Further explore the collateral damage on communities, on partnerships. Examine the impact of changes in the HIV epidemic on correctional health, and advocate for change to rein in what is clearly a socially toxic and disruptive force. So I'm going to leave it there just so that there's more opportunity for discussion and talking rather than me doing all the work. So questions, comments? Don't be shy. I know it's hot. Yep. Are the first drugs that people get when they get out of prison paid for? Yeah, so the medicines that they get when they get out certainly are free, so you get a little bag. Here in North Carolina, we give a 30-day supply. In Texas, they give a 10-day supply, like I said. And then how you get your medicines after that could be variable. So for women, many are on Medicaid. Medicaid will provide medications for free at any local pharmacy. For others, like men, it may be that they have to get on an AIDS drug assistance program, ADAP. Every state runs an ADAP program that provides medications for free for people who meet poverty requirements. If you're getting out of prison, you meet the poverty requirement. In that Texas study I showed you, 100% of them qualified for the free drug program from the state. And they still didn't pick up their meds. So, and it just required a 1-800 call to find out, to activate your medication and go to the nearest pharmacy. So the question is, are people directed to know that there's these resources? It's very interesting. In that study in Texas, I didn't go into the details, but there was, for a brief time period, a program in Texas to get people to fill out forms for that program before they got out and get counseled in how to do it. Those people had a slightly better rate of getting their medicines, but it was paltry. I mean, it was still horrible. So I think it's part of it. I think it's not so much the program not being accessible. I think utilization is low. So there's the one part of that, which is make sure it's accessible. And most of the people who went back in Texas went back to the major cities. They went back to Houston, they went back to Austin, they went back to Dallas, they went back to Fort Worth. It's not like they were going out to some podunk place. So, I think that the access was there. They know where the clinics are, but it's the utilization. Am I going to really go there when I'm trying to find a place to live, when I'm trying to find a job, when I'm trying to get back with my, my baby's mommy? It's just all sorts of things going on at the same time. Yeah.
This is sort of along the same lines, but you mentioned that a lot of the people who are going into prisons already have HIV,
Yeah.
and then you also mentioned that a lot of people who have HIV aren't receiving antiretroviral treatment or don't really have it. Or just can't really get any kind of care at all. So I was wondering if you've noticed if people who have HIV are maybe committing crimes or doing things in part to receive that kind of care.
The question is, given that there's a lot of people who are not in care and maybe have trouble accessing care, are there some people who try to get incarcerated in order to get the kind of care, to get higher quality care? That cascade I showed you, I think it's really interesting to look at this. I think this is really fascinating. I think that there's a lot of people who are aware of their infection but not linked into care for the same sort of reasons that people coming out of prison don't get into care. There's just other things in their life that are competing with that, and this is not a high priority for them. There's denial, there's substance abuse, mental health, whatever. That really is just amazing to me and many people looking at this. So I think, again, there's an access problem. Some of these people may not be able to feel they can access high-quality care, and others who do. But I think it's not really a reason that people get incarcerated. What we used to see was that people who would be reluctant to leave prison. I had a lot of patients who said they actually felt that they were doing so well in prison, they were scared when they got out that they'd no longer be able to take their medicines and get the kind of care. And I believe that certainly there's places in the country where people can't really get good care outside of their correctional facility. I think that occurs. I think here that's not the case. I think the public health infrastructure in North Carolina is generally very, very good. So I don't think it's as much an access problem as a utilization problem, although some of you may have experiences that will prove otherwise.